Um, we have so many of you from so many parts of the world. Thank you for joining us to this webinar, Women in COVID. We have been doing this series for the last few months to unpack several of the issues we so deeply care about and explore and expose the links to COVID. So today we are looking at women in COVID, and moderating the session is Maia Olsen. She works with Partners in Health. She's a fierce global health advocate and was the co-chair of the Women NCDs task force. So over to you, Maia.
Sorry, I was muted for a second. Thank you so much, Nalini, and thanks everyone for being here. It's an honor to join all of you. The work that has always connected what Nalini and the team at Arogya World has been able to lead with what we're doing at Partners in Health has been this intersection between non-communicable disease and women's health. I help manage the NCD program at Partners in Health. But I think through that collaboration, I think we're all here because we're particularly interested in addressing some of the inequities and vulnerabilities that exist in health across gender, across poverty, across some of the conditions that are more neglected. And so I'm very, very happy to be here. I think as we all are grappling with COVID being this kind of new unprecedented threat, we're all learning, we're all trying to figure out how to do the best for our patients, for our organizations, for the women's health movement. And so I'm very excited to hear and learn from two experts in their field, and really look at the role that women play as caregivers in formal and informal sectors, how COVID is impacting girls and women around the world, and what we can do as advocates, as researchers, as implementers, to really address the issues we all care about around equity and health in the time of COVID. So joining us this morning or afternoon, depending on where you are, we have Dr. Sonja Rasmussen, who is a professor in the Department of Pediatrics, Obstetrics, and Epidemiology at the University of Florida. She also has had a long former career at the CDC, where she had leadership roles in the National Center on Birth Defects and Developmental Disabilities, in the Influenza Coordination Unit and in Pandemic Preparedness, and in the Division of Public Health Information. And then we also will hear from Soon-Young Yoon, who is a longtime activist advocate in women's rights. She's currently the UN representative of the International Alliance of Women and the chair of the Women's Environmental and Development Organization. So we're going to start with a brief presentation by Dr. Sonja, looking at COVID-19 and pregnancy. And we really would like this webinar this morning to be interactive, so please ask questions. I will be watching for the chat to bring it into the discussion after we hear from Sonja and from Soon-Young. So go ahead, Dr. Sonja.
Okay, great. Can you put the slides as slideshow? It'll be easier to see. Great. So it's my pleasure to be here today to talk about COVID-19 and pregnancy, and talk about what we know and what we don't know, and there's still a lot we don't know. The next slide, please. Whenever we're working on emerging infection, and I've worked on several emergency responses at CDC and oftentimes focusing on pregnant women, there are a lot of key questions that need to be asked, and these are some of them. First of all, are pregnant women at increased risk for getting more sick? As, for example, what we saw with H1N1, where we know pregnant women were more likely to be hospitalized, and to die. What are the effects of COVID-19 during pregnancy on the embryo or fetus? And of course, we just had the experience with Zika, that where women got sick during pregnancy with Zika, and then their babies had severe effects, had birth effects. And part of that question is, can the virus that causes COVID-19 be passed from the mom to the fetus during pregnancy? And then the final question, I think, for here that I think we really need to start thinking about is, what are the unintended consequences of the COVID-19 pandemic, of the interventions of the COVID-19 pandemic? For example, the effects of lockdown on pregnant women and their babies. And we certainly have all heard about the effects on immunizations, that kids aren't getting their shots like they should, and that's going to cause a potential, if we don't get them to catch up on their shots, there's going to have severe effects on public health because of that. So what are the effects on pregnant women and their babies with those interventions from lockdown? Next slide, please. So many of the early studies that were done looking at pregnant women and comparing them to other people compared them to everybody with COVID. And of course, that includes a lot of people that are older, and it includes men. And we know men seem to have more severe effects of COVID-19 than women. And it's not really fair to compare pregnant women who are generally young to people that are 70 or 80 years old. Next slide. So this study here that I showed you the first page of was just published a few weeks ago, and by the CDC, and it had very large numbers. It's not a perfect study. There was some missing data, but I think it really gives us some information. And this is the basic table that was published there. I've cut some of it down, but you can see large numbers of pregnant women, about 8,000, more than 8,000 pregnant women, and then a comparison group of non-pregnant women of childbearing age. So comparing apples and apples versus apples and oranges for some of the other studies that have been done. Here you can see on the right column there, it looks at the adjusted risk ratio. So how do pregnant women compare to non-pregnant women as far as the likelihood of being hospitalized, being admitted to an intensive care unit, of needing mechanical ventilation, that means needing a ventilator or a breathing machine, and then what's the likelihood of them dying. And here you can see that there was a statistically significant, so the 95% confidence intervals don't overlap, one, for those of you that are not statisticians or epidemiologists. And there is, you can see that there was an increased risk of hospitalization, of ICU admission, and of mechanical ventilation, but not an increased risk of death. I want to just put a caveat here that this, as I told you, this wasn't a perfect study, and the data on hospitalizations were unable to say if the woman was being hospitalized for something pregnancy related or whether it was related to COVID. But I think this does suggest that pregnant women are more likely to have severe effects. They're more likely to end up in an intensive care unit or more likely to need to have a ventilator. Next slide, please. So this has led CDC to say that pregnant women are a group that may be at increased risk for severe illness compared to non-pregnant women. Next slide. So what about the effects on the fetus or newborn baby? And this is a study, this I think is the best study that's out there, pretty big numbers, and from the United Kingdom from the time of their pandemic. And this is looking at the data from the UK obstetric surveillance system. And here you can see, this was a study that was put together in 2012 after H1N1 and then was hibernated, waiting for a pandemic to occur. And there were about 427 pregnant women, although a number of them had not delivered by the time of the paper being published. Next slide. So this just shows that there were very few women that were in this study that were exposed in the first and second trimesters. So just to say that we know very little right now about the effects of COVID-19 on first and second trimester pregnancy. And of course, early in pregnancies when you would expect to see problems if the baby's gonna have birth effects like Zika. Next slide. This slide shows the gestational age at the time the baby was born among the babies that had been born by the time the paper was published. And here I want to really focus on that bottom line there, the 37 weeks of pregnancy and later, that's a full-term pregnancy. So that's, you can see 74% of the babies were full term or later, but that means 26% were preterm, and that's higher than what you would normally be seeing, and that's of concern. Next slide. And this slide just shows the percentage of those babies that needed to be admitted to a neonatal intensive care unit. And I have to say, you know, from working at a hospital for many years, a baby that's admitted to the NICU is a baby that's pretty sick. So these are babies, this is higher than you would normally expect of newborns. So it does say that these babies that are born to moms with COVID-19 are tending to be more sick. There had some babies that had a positive SARS-CoV-2 test, although none of those were convincing that it was transmitted during pregnancy. Next slide. But just this last week, this paper was published, and I think this is the first paper that is convincing that SARS-CoV-2, at least convincing to me, that SARS-CoV-2 can transfer from the moms to the baby. There was SARS-CoV-2, the virus that causes COVID-19, in the amniotic fluid and in the baby after birth, and the baby did have some illness related to it, although the baby recovered. Next slide. So I want to just show these. Two of these are from preprint servers. This has been one of the things that's been the most challenging, keeping up with the data. And in COVID-19, there are now over 400, 500 papers, somewhere in that range, between 400 and 500 papers, depending on how tight you put your lip search in PubMed on pregnancy and COVID-19. And these are some from preprint servers. That means they haven't undergone that normal peer review process that papers need to go through, but they're starting to show that there may be some effects on women without COVID-19 of the lockdown, of staying at home. And these were, one was from Denmark and the other was from the UK. So I think we have a lot of questions. We don't know the effects right now, but there do appear to possibly be some effects of the lockdown on moms and babies. Next slide. So these are just the conclusions, and the bottom line is many questions remain. It does appear that pregnant women get more sick. It does appear that there's some effects on the babies. The effects on the interventions are really at this point unknown. And next slide. We covered a lot of this in our paper that was published in JAMA on June 5th, as I mentioned though. So if you want to look, that's available for free on the JAMA website. But as I've told you, a lot of the information is changing rapidly. Next slide. So I think the best place to get information is on the CDC website for the very latest information. Thanks so much.
Thank you so much. Thank you so much, Dr. Sonia, and we'll circle back on some of what you presented, and if people have questions, please do include them in the chat. We're going to move along to one more brief presentation before we get into the question and answer portion. Soon-Young is going to be presenting on a bit more of a broader societal look at the impact of COVID and women's human rights and the care economy in particular. So please do go ahead.
Thank you so much, Maya. Let's see, let's get this going. Here we are. So what do we see now? We see that during COVID, the inequalities, whether they be by gender or ethnicity and race, and injustices are really laid bare. There's no way we cannot see that at this point. So the World Bank estimates that 700 to 100 million people, mostly in South Asia and Sub-Saharan Africa, will fall into poverty. Excuse me, just a minute, let me go back there. Will fall into poverty. And I think what I'm hearing is more alarming than anything else, is that this is happening at a faster rate than at any other time in modern history, and that includes the financial crisis of the 1990s. Second statistic to pay attention to, women who make up more than 70% of the 136 million health and social care sector workers, that's people we can actually count, are actually earning, prior to COVID, an average of 11% less than men doing the same job. Then we have women in the informal sector. 61% of women workers are actually in the informal sector. These are women that you often are in a way invisible to us. They're domestic workers, perhaps migrant, undocumented migrant workers. In the Africa region, they're the people carrying food. They're part of the food security system. But these women in the informal sector have no social protection in most countries, health or job protection. The informal sector also includes those subsistence farmers and seasonal workers who are often not counted in the employment statistics. So what I want to point out here is that we often say the problem is structural, and these two figures tell me everything. So one figure that came out is the wealth and poverty figure. 1% of the world's billionaires had more wealth last year than 4.6 billion people. So the inequality is so clear, and it is in that structural framework that we find women's poverty. Then we have another statistic that says we have enough money to do that social protection if our priorities are straight. And that figure shows that the top 10 countries have budgeted $1.4 trillion just for defense and the military. So the burden of unpaid care work on women is probably something that everyone in this group already knows. You know that there's an interesting phenomenon as well of a little bit of shared care work going on, but we know that disproportionately this really is falling on women. There was one report from Hawaii when they said, look, you know, there's unemployment everywhere else except in the home, and women are really, really working hard. They're in overdrive. This unpaid care work phenomenon does vary by region, and we have something from Latin America on the value of this unpaid care work. So you have from Ecuador something like 15%, and then you have around 24% from Costa Rica, which says, you know, that the value of this unpaid work, in a way that's, if we were to monetize that unpaid work, you would find that it is that percentage value of the GDP. And here I'd like to point you in the direction of a really interesting report that came out very early by the UN Secretary General on the impact of COVID-19 on women. So what do we need to do? The feminist and women's movement can really focus on these inequality issues, but also on those United Nations commitments that we can lean on for accountability. So since not everyone in this group may be acquainted with these documents, I'd like to point out 3 different areas. One is the Beijing Platform for Action. This is a document, a policy document agreed upon 25 years ago. We are celebrating that in Beijing plus 25 this year when the UN Fourth World Conference happened in Beijing. So this policy document has 12 critical areas of concern. And the ones that are perhaps most relevant here are the ones on health, a specific one on health, one on environment, and one on human rights. But this is a policy document. So it needs some teeth. It needs some legally binding weight behind it. And that's why we often talk about combining that with the legally binding human rights document for women called CEDAW. That's the Convention on the Elimination of All Forms of Discrimination Against Women. And there are other human rights documents of relevance, the Convention on the Rights of the Child and so on. But if we just focus on these two, one policy, one legally binding, we have a very powerful set of commitments that we can call governments to take task on. Then we just finished 2 weeks of something called the High-Level Political Forum, where the governments had committed to really ambitious sustainable development goals. And those included goal number 5 on gender equality and women's empowerment, goal number 3 on health, and within that goal on health, I think what's really interesting is that we have very specific targets on non-communicable diseases, which many of you may know, is a very high risk factor for women for COVID-19. And we also have there a specific goal on health, goal number 3. And within that, you have a specific target on the WHO Framework Convention on Tobacco Control. So why would we use these targets? Because the Beijing Platform for Action does not specify targets. Convention on the Elimination of All Forms of Discrimination Against Women and human rights treaties generally do not establish targets. The SDGs, or the Sustainable Development Goals, are time-bound. We are now in the 5th year review, and they therefore give us global sets of targets that we can work towards. I want to mention one more SDG target, which is SDG target 11 on cities. Cities turn out to be extremely important in dealing with climate change and with health services, social protection, and inequalities in ways that we probably didn't realize before COVID-19. And that's probably because we're seeing highly urbanized parts of the world being most affected. So let's pay attention to leadership in the cities. So in this feminist and women's movement action plan process, we want to break down silos. That is, we want to stop talking just about public health as a health crisis. We want to build a transformative framework that we keep talking about a holistic approach, but how exactly do we do that? We think that the human rights frameworks actually gives us a roadmap on how you're going to do this and how you're going to actually break down these silos in a meaningful way. Here's one of my favorite posters in the whole world. This is from the WHO monograph on women and tobacco, gender and tobacco. Human rights really matters for women. As you know, we know that exposure to air pollution, tobacco use itself, and exposure to secondhand smoke is a risk factor for women. Women make up somewhere around 12 or 13% of the world's smokers, but they do account for more than 64% of deaths from secondhand smoke. We used to talk a lot about maternal smoking being dangerous for women and for children, but take a look at paternal smoking, which is a violation of a pregnant woman's right to clean and safe, and I would say work environment, since so many women are doing care work in the home. So during sheltering, one of the things that we cannot see, which may be very important, is the question of whether or not pregnant women are in fact more exposed to the dangers of secondhand smoke, being required to stay at home. And which silos are breaking? Last week at a seminar, Minister of Finance from Italy said a really telling, made a really telling statement. He said, our allocation of finances in Italy, we used to look at climate change as the major threat to our economy. We are now putting health on top of the list with climate change. So as you know, we only have 10 years left to change course to a 1.5 degree planet, after which all of our health is in danger. So let us look at breaking the silo between health and climate change. The second one, which probably everyone who is in the formal working workforce understands now, is the connection between health and economic impact. And finally, health and inequality we just discussed. We have a rise in gender-based violence, which we'll discuss a little bit more later. But here are some of the silos that are being broken in our process as we come to understand better the impact of COVID-19 on women. Thank you very much.
Thank you so much. It was a really, really helpful overview of the intersections across health and poverty, climate change, environment, through COVID, but also some of the international infrastructure that we as advocates can really push towards and sit within for change. I think the points around the economic impact and poverty particularly resonate for the work that my organization does clinically and in areas of rural poverty. I know you mentioned cities as well, but I know we all know that many times girls and women have to travel such a long way to get to facilities, and through COVID, the risk of infection to go to the facility has increased. And so thinking about ways to make sure we're not disrupting services and furthering the inequities. An example that we've kind of used in chronic diseases is using community health workers to deliver food packages and some of the sort of economic social support, as well as cell phones and data and 3 months of medications so that people can stay safely at home. And it'll be interesting to hear kind of more of your advice as we move through this. We are going to now kind of have more of a conversation. There's a number of questions. I'm seeing things come through the chat, and I'll try to bring those into the conversation. I'd love to start with Sonja. There's a couple of notes that people have been sharing in the chat, kind of curiosity about whether or not there's anything known about the impact of COVID on potential genetic disruptions for pregnant women, or observations more generally in the studies around the age of women and nutritional levels. But I'd like to broaden that question a little bit. Sonja, you had mentioned kind of a brief clinical picture. There's been more risk of sort of severe complications in men rather than women. I'd love to hear more about sort of what's been the differential impact across gender, and what don't we know? Where is the data really lacking, and making it difficult to move forward as researchers and as clinicians? Oh, I believe she needs to be unmuted. If you can help with that, Lauren. Thank you.
Okay, great. So I was trying to spend a lot of time getting unmuted and making messages, so I might not have heard the question, but I think there was a question about differences between men and women. Is that what the question was? I saw some other questions about birth effects and what's known about genetic changes. We have no information about anything about that right now. I think because of the recent experience with Zika, I think we, especially now that we know that at least the virus can cross the placenta, that makes us concerned about the effects on the fetus early on. We also know that women that have fever early on in pregnancy have an increased risk. Fever, no matter what the cause is, or even hot tubs or other things that increase a woman's body temperature can increase the risk of certain types of birth effects. So I think this is an important question, but right now we don't have any information. We don't have information on that, on genetics changes, on birth effects changes, and I think that's something that we're really going to have to do some careful research to find the answers. With regard to the difference between men and women, this is something that actually was shown early on from the data from China. It's been from Europe, especially from Italy, and then the data that are being seen from the United States, that it appears that men are at increased risk of severe disease compared to women. And why that is, we don't really understand, whether it's related to something with hormones, whether it's related to underlying conditions, that men may be more likely to have some of the kinds of underlying conditions that put you at increased risk for having COVID-19 or severe effects of COVID-19, or whether it's behaviors that men do, like an increased risk of smoking. We don't have a good answer to that, but men clearly are at increased risk of severe disease compared to women. I hope that answered your question. So
it did, and I know some of the answer to that question is what we don't know, and so helpful to understand where we we really need to come together as a research community or as kind of policymakers to get that data and to move forward. I think, Soon-Young, you talked quite a bit about women as care providers, both kind of formally and informally. I know mental health is a topic that's been covered in this series in the past, and we certainly don't need to take a ton of time with it, but I'd love to hear from both of you in your own contexts. What is the potential of the mental health impact of COVID, especially on women doctors and nurses, but also in the home, as in the informal caregiving roles that so many girls and women end up in. Soon-Young, would you like to start with that?
You know, you've asked the wrong person. I certainly am not capable of answering that question. I think what I see and hear is the only thing that I can comment on, and I'm seeing and hearing a little bit from other regions, the Arab region, so on. The rise in violence against women is something that it has been very early on reported. I don't know if you want me to go into that now. I would like to hear from Sonja and hear if she's heard anything from the side from health workers, what's happening there. Thank you.
I know there's a lot of discussion right now, the effects on women in academics, and I realize that's a narrow field, but it is something that has been discussed a lot recently at my university, that a lot of the men are, you know, they're at home, they're not having disruptions in their lives because their partners are taking care of the kids maybe, but that the women who are on the same path trying to get tenure on a tenure track position, their productivity has gone down because they're trying to take care of their kids. They're trying to homeschool their kids basically at the same time. Of course, that's not everybody. Some dads are doing their fair share, but there has been a lot of concern, I know, from academics. I haven't seen a lot of research data yet on that, but I think that's the kind of thing that another area I think we really need to look at, what the effects on mothers and fathers of the lockdown and the stay-at-home orders and the kids being sent home from school.
Can I intervene there for a moment? Sonja, I know you mentioned in one of our conversations you were in close touch with women health workers and their states of how they're coping with crisis. And I wonder if there's mental health concern there that you might want to report on. I think it would be very relevant here.
Yeah, again, this is anecdotal information.
It's good, it's good stuff. Yeah. It's helpful.
Yeah, the anecdotal information shows that men and women, healthcare workers, are really having a lot of burnout. And, you know, I think healthcare workers were having a burnout beforehand, and that this outbreak has, like a lot of things that were an issue before, has brought even more issues to the fore. I think some of it is, I think a lot of us healthcare workers, including me, are frustrated with the, you know, that people don't seem to be listening to the experts. They seem to, at least in the United States, to be listening to people that have very little background on epidemiology and infectious disease. And that is a significant concern when, you know, a lot of the brunt of the disease is on those healthcare workers. They're the ones that are putting themselves at risk every day to take care of people in an emergency room. So I think, you know, I think we're going to see long-term effects. Some of my colleagues that have been taking care of patients in really very hard-hit areas are saying things that they think there will be PTSD, kind of post-traumatic stress disorder afterwards because of the effects of this.
Yeah, so that's what I was hearing as well.
That's really helpful. And Soon-Young, you kind of anticipated the direction I wanted to go. Do you mind covering the gender-based violence question and some of the ways that the UN system in particular has been looking at that through COVID.
Yeah, I think one of the first agencies very early on in the epidemic that we heard from was UNFPA, the one that takes care of sexual and reproductive health and rights. And they were reporting, they had an estimate. They said they expect that about 15 million more cases of domestic violence are happening for every 3 months of lockdown of COVID. And then UN Women reported something, the UK seems to be a good source of information on this, that in the UK we had something like 22% of the frontline services, which includes the crisis centers, helplines, shelters, reported that they could not support the adult victims of abuse, and 42% said they couldn't support children. So you have a lockdown where people can't get to their shelters to provide the services. You have a lockdown where women are stuck with their abusers, and therefore, you know, there is reporting that seems to be increasing to those centers. At the same time, it's entirely possible that in some situations you have underreporting because women can't get to secure locations and don't have access to the kind of communication that they would need in order to do the reporting. All in all, I think what it points to is that we need to find innovative solutions in these crisis situations where you can't have services. And one of the really interesting ones that I was reading through was in Peru. Apparently in Peru, what they did is women's services decided to develop a mobile unit that would actually be able to respond at the homes. And another more long-term one that certainly would be useful to put in place is in the formal workplace, where you create a program to work with men in order to engage them, whether they're in the workplace or in trade unions, to be the champions of preventing domestic violence, and particularly alerting them to the possibility of rise in domestic violence in crisis situations. We know this also happens when you have disaster for some reason as well. And in a lot of the developing world, the long-term effect of a disaster, a crisis, leading then to an economic crisis, leading to poverty, ends up with violations against girls because they are trafficked or married off at an early age. So the multiplier effect of a crisis is really of great concern because the violence part is just a part of a series of disasters that are happening to women, and they don't have the resilience built in to be able to survive those well. And it happens to all age groups, which is very concerning.
It's such a challenging topic, and I know it's been kind of multiple people have brought it up in the chat. I know we have time with you at the end for some of kind of your recommendations for action, so I'd be curious to hear more there. There was a very specific clinical question kind of around gender-based violence that we may not know the answer to, but I believe the person asking it was curious if there's been any sort of study or data out there on gynecological diseases or conditions that have been identified as a cause of domestic violence through COVID. I would imagine that level of specificity on data isn't available quite yet.
Sonja, that's not my question. That's yours.
And the information on that.
Yeah. So let's move on to another question that was asked for Soon-Young and her experience with CEDA and some of the institutions she's represented. There was a question around what are some of the special provisions to increase kind of the access to livelihood for women or access to employment through COVID, or what was in the mix around social protection and economic empowerment that is either still really an opportunity through the lockdown or becomes more challenging given the lockdown?
Let me reinterpret that question.
Go for it. Absolutely.
So what I find is that a lot of people are asking what's next. What's next? And because we need some hope at the end of this tunnel. So my interpretation of the question is not only what's happening now, but what could we put in place, say with CEDAW or with women's human rights, that would take us to a better place? The good news is we actually have one feminist recovery economic plan. And we discovered it just about 2 months ago, but the Women's Commission in the state of Hawaii has published a feminist recovery plan specific to Hawaii. My brother used to live in Hawaii, and I have visited the state, and I think it is in microcosm answering a lot of the questions that have global significance, which is why last week we actually had a panel that included the executive director of Habitat, which deals with human settlements in the UN, and also the person who prepared that report. So what do we see in that report? What we see is an attempt to translate human rights and feminist vision into an actual practical setting in which you have a huge indigenous population of Hawaiians, but in which you have such diversity that the inequalities during COVID were really, really very apparent, in which you have a military base, which is absorbing a lot of the attention and whose economy is devastated because it depended on tourism. So how do you rebuild such an economy that takes care of social protection? You make sure that universal health coverage is in place for everyone. And some of those very basic in-place things, which are human rights things, I think are going to be part of our re-envisioning with women's human rights. And as as Mamouna Maud-Sharif, who's the executive director of Habitat, said, she's an urban planner, she said, you know, if you plan a city for women, you plan it for everyone. If you plan a country for women and with women, you actually plan it for everyone.
It's a really, really powerful framing and just a kind of thing to keep core for all of us. I'm going to go back a little bit more to the specific. There's a number of questions in the chat around the impact of lockdown, not just on kind of economic rights and access for women, but on access to abortion and contraception, and a number of questions around menstrual health. And I'm not quite sure between the two of you. I feel like this might be something a little bit more for Sonja, at least from the US context, but I'd love Soon-Young's thoughts on kind of access to reproductive services and menstrual health through how the pandemic is impacting it, and where are some of the challenges?
Yeah, I'm not aware of a lot of careful studies being done. Again, I've seen some anecdotal reports of decreased access to abortion services in some states. And, you know, right now, the healthcare system is focusing on the greatest needs. I know that I'm working with an gynecologist on a genetics project, and they had stopped seeing routine GYN patients, so we couldn't start our GYN project. Well, that means those women wouldn't have access. Now, very quickly, my university worked to do telemedicine, and so we really, for a while, everything that wasn't COVID was switched to telemedicine. We all got up to speed, and so she was able to start seeing patients through that system. But I think there are a lot of places that weren't able to adapt as quickly, and so I think there have been decreases in reproductive health services, and certainly what I read in the newspaper, abortion services too. So I think we're going to be learning for years, just like after Zika, we are still learning about the effects of Zika, H1N1 influenza. We learned for years about the effects of H1N1. I think this is going to be even more so, that we'll be trying to understand all of the effects on children's health, pregnant women's health, everybody's health, because I think that's going to be an impact very widely on health, on non-COVID related things. People who missed their colonoscopies, missed their prenatal appointments, decided to deliver at home because they were worried about going to a hospital, and so on. Lots and lots of issues here that I think we need more information on.
That's helpful. Soon-Young, did you want to comment as well?
Of course, I have lots of questions for Sonja.
Go for it.
Sonja, now I gather you've had direct experience dealing with pregnant women and babies in different situations. You've mentioned comparatively. So I wondered if you could give us an example of how, as a physician, dealing with pregnant women, COVID, and with children might be different from something that you've dealt with in the past as a practitioner. I think it would help us understand a little bit more what's going on.
Well, I think the biggest thing that's different here is that the severe disruption across the board, you know, with really for a while, almost everything stopping, everybody staying home, schools, people not going to schools. You know, I think the other responses that I worked on, you know, I worked on H1N1, on Zika, on Ebola, and in the United States, most of our lives pretty much went on day to day, unless we were one of the people that got one of those illnesses. Or I think there was a lot of fear related to Ebola, although I think, you know, the frank risk to anybody in the United States was pretty low. But I think this is just a whole different situation because of the interventions that have been taken. So what advice would I have for women planning pregnancy?
Yeah.
I see that note there. I think the most important thing, actually for everybody right now, I think people, I've heard young people say, well, it's a mild illness. I don't think we know the long-term effects. And we do know that for some viral infections, you can have long-term effects. Certainly, we are starting to see that a lot of people continue to have fatigue, or some people even more severe effects long-term. So I feel like pregnant women and everybody needs to do their best to not get COVID-19. And that means doing everything that you keep hearing right now of watching your distance, try to stay at least 6 feet away from people, wearing a mask, and washing your hands. I mean, those are the three things. And I think right now, really important to avoid crowds, avoid closed-in places. Do what you can to avoid getting COVID. I don't think avoiding a hospital when it's time to deliver your baby is the smartest thing. I think we're starting to see some of the negative effects of that. So I think hospitals have worked really hard to make them a safe place for women to come and deliver their babies. So that's.
We could also all move to Europe, where they've got it under control. Have your pregnancy in Denmark or something.
Yeah, I really think in the United States we need to start taking this seriously. I think we thought somehow we were going to be different than other countries, and I think that was perhaps a naive thought. But I think it's time to take it seriously and really try to drive our numbers down, or we're going to have long-term health effects that we're going to see for many, many years.
We've had really interesting and challenging conversations across Partners in Health has gotten involved in the U.S. COVID response in Massachusetts and is doing technical assistance in other states in the U.S. And in the early couple of weeks, our West African programs, which are usually our most vulnerable, were the most prepared to do lockdown, to put the provisions. They already had PPE. They already and so they're differentially kind of our West African, Liberia, Sierra Leone, were ready in a way that the US wasn't, Malawi and Southern Africa wasn't, some of our programs in Mexico and Peru weren't. And so it's been a very strange comparison. But I know kind of, Sonja, you're grounded in the US, and Soon-Young, you work kind of much broader than that. I think one other major moment that has rocked us in the last couple of months has been this conversation around racism, both in the US through some of the murders recently and the response to that. But I think it's a larger conversation around anti-racism, anti-colonialism, the kind of inequities across the world. And so before we kind of talk a little bit more hopefully about some of our recommendations for action, I'd love thoughts on just what's been the impact of COVID on women of color and the vulnerabilities there.
Yeah, across the board, we're seeing that persons of color are at increased risk for getting COVID-19 in the first place, possibly because they're more likely to be essential workers, and then of having adverse effects from COVID-19. And whether that's access to healthcare or systemic racism, I don't know that we completely understand the reasons for that, but those are the people that are having the highest risks of hospitalizations and of severe illness. I think it's something that we're even seeing in somebody asked a question about the Kawasaki-like disease that's being seen in children, or now it's called multisystem inflammatory syndrome in children. That is also being seen at higher rates among children of color. And it's something that I think has to be a high priority to address in the United States. And I would guess other places too, but definitely I know in the United States it's something that I think we really have to get to the bottom of and figure out how to not make it so that, you know, it doesn't seem like, it just doesn't seem right that there is a certain portion of the population that's taken the biggest brunt of this pandemic.
Absolutely.
Sonja, I don't know if you remember that report from Singapore where they were saying, you know, the curve has been flattened, they're doing fine, until they found the cluster, which was actually not among the Singapore citizens, but in their migrant population in a whole building. So it turns out that inequality is bad for everyone because they weren't paying attention to those people who actually are their base workforce, but who didn't have access to the same kinds of health equality that other citizens had. That's what strikes me in the issue of race, is that kind of inequality turns out to be something you can't afford in an epidemic like this. The other thing that occurs to me is that we're not paying enough attention to that adolescent group and young people in those groups. I'm not hearing enough about their behavior, about their concerns, and how they're being affected, because it's like a blank, you know. What are the teenagers doing who are being told they have to go back to high school or not going back to high school? It's a different category than young children. So let's start paying more attention, I think, to youth in this epidemic in general, and particularly in those groups.
Yeah, those are such important points. I know we want to end on action and how we as a community can come together against many of the issues that we were addressing today. Soon-Young has a couple of slides, so I'm going to start with Sonja. Advice you would have for governance, for researchers, for advocates, for clinicians like you over the next couple of months and longer.
Yeah, I think you know, I'm a researcher, so I'm also a patient care person. I'm a doctor, but I feel like the most important thing right now is for us to collect as much data as we can and then act on that data. So as we're seeing that there are, for example, increased risks during pregnancy, how do we help it so that pregnant women have a low risk of getting COVID-19 in the first place? These are people we want to protect. How do we make sure that people who are at highest risk are the first in line to get vaccines? So I think those are the kinds of things we need to understand: who's at highest risk and how to affect that risk. And that is the challenging thing in an emergency response, is you're collecting data, got to act on it as quickly as possible.
It's helpful. And Soon-Young, I know you have some thoughts as well.
Well, I don't know, just to react to Sonja, what she's telling us is we don't have that data. It's not being collected, and that's a great concern, of course. Yeah, I have a couple of slides, and the reason I showed the slides I explained is because then Maia can share them with you afterwards, because I really want you to pay attention to these ideas. So recommendations. So if we go to recommendations, you know, why do we need a feminist or a human rights recovery plan? You could put it this way. You could say that our ecosystems, our planet, that must sustain all human health and livelihoods are under threat. That's the bottom line. What do we need to do? I know we all have these important policy ones, but some that sometimes are overlooked are to value and invest in the care economy. We need to make sure that our fiscal stimulus are extending social protection to informal workers. And also that the public health messaging that we're doing has to be very tailored to specific populations of vulnerable women. So migrants, indigenous women, refugees, internally displaced peoples, and rural areas are really at risk. And who should be making this plan? Of course, you know, we have to make sure that we are in that room when those fiscal decisions are being made and where that money's going, and when the recovery priorities are being placed. Now is the time to think about this. Now is the time to anticipate that we will have a post-COVID time. And the things that are happening now, the decisions that are being made now are going to decide what that outcome is going to look like. As a starting point, I really like this simple 6-pointer that came out with WHO's Manifesto for a Healthy Recovery, which is to protect and preserve the source of human health, invest in essential services, not just for everybody else, but start with your healthcare facilities. Ensure a very quick and healthy energy transition, which I have to say is also gender just, and promote a healthy, sustainable food system in which, as I mentioned previously, in a lot of regions, women are at the core of that food system. Build healthy, livable cities, that'll be good for everyone, and stop using taxpayer money to fund pollution, divest from the fossil fuel industry. So Maya's gonna send all these to you so you can all do these. Oh, and I almost forgot, if you're a young person, the most important thing you can do on health and climate is vote. Thank you.
Thank you so much. And Nalini, I believe you're closing things out.
Yeah, thank you. What a sweeping conversation we've had on so many aspects of this issue. We wanted to do this webinar series and this particular one only to stimulate thought. So thank you to Sonja, Soon-Young, and Maia for the sweeping conversation. As I said, I've learned so much. We've thought about the impact on pregnancy, on health and healthcare workers. Hey, if 70% of the world's healthcare workers are women, hey, we need to preserve their health at a minimum, to ensure that all of us stay healthy, and particularly the emotional aspects and mental health aspects, and then all of this women's movement and women's rights things. I can't help but think that, hey, in the last few months, lots of people have lost jobs, but I think women will find it harder to get back into the workforce. And I, for one, believe that women's movement has probably taken a couple steps back. It's nice to see that there are some positive action items we can all take. And there is a couple slides, but it's time, and I'll share the slides with you guys, but we have done a 10,000 women study, Arogya, and which has shown that unpaid care is a major cause of chronic diseases are a major reason why women are taking time off from work to take care of people in their home with these chronic diseases and are not cared, are not paid for that care. So in this going forward, we really have to pay attention to all aspects of the care that women provide. So I'll stop over here. I wanted to say that we will have another webinar exploring further the fabric of society and the role that women play in that. We'll unpack that a bit more with another webinar that Gloria Barone, one of our board members, will lead in a couple of months. But the next webinar is on obesity and COVID, and this is with Dr. Bob Kushner from Northwestern University, one of the foremost experts on on obesity and weight loss. So we're really fortunate that he will speak to us. We'll again get back to race, I'm sure, and we'll talk more about chronic diseases and obesity. It's on August 8th at the same time, 11:30. Please join us. And we'll send you the link to the recordings, and we'll send you a couple more things that you can look at. So thank you very much. Please think about this issue. This is a serious issue, and let's all pledge to take some action in our own spheres of influence. Thank you all. Thank you to the speakers especially. Thanks.
Thanks so much, Melanie. Take care, everyone.